Okay, hello, welcome everyone. Can you hear me clearly? The mic is working, great. Welcome to our special forum on patient-reported outcome measures, or PROMs as we'll refer to them today. My name is Sarah Kirby and I work at the George and Fay Yee Center for Healthcare Innovation, and I'm helping to lead this initiative to develop a provincial approach to the collection and reporting of PROMs in Manitoba. There is a strong appetite for this work, as is reflected in part by the number of registrations we had for today's event. There's over 150 people registered today, many from outside of Winnipeg in regions across Manitoba and from provinces, other provinces outside of Manitoba. Members of the public, patients, healthcare professionals, healthcare practitioners, researchers, health systems leaders, health policy makers, and students are all participating today. And I know that many of you are participating online. We have a lot of online participation, so I want to encourage you to use our Poll Everywhere app to interact with us today. To do so with your phone, you need to simply text to the number 37607 and then put CHIMB 622 in the message portion, and then press send, and that will link you to this session today. You can ask questions at any point. Myself and my colleague Waterman will collect your questions throughout the presentations, and then we will ask your questions during the Q&A session. I'd like to also acknowledge that this event today is being held on the original lands of the Anishinaabe, Cree, Oji Cree, Dakota and Dene people, and the homeland of the Métis Nations. We respect the treaties that were signed on these territories, and we acknowledge the harms and mistakes of our past, and we are dedicated to moving forward in partnership with Indigenous communities in a spirit of reconciliation and collaboration. The purpose of today's meeting is to come together to launch discussions on how to best move forward with a provincial strategy for patient-reported outcome measures. And we are moving forward with a provincial advisory group who will lead this work. And many of you are in the room today. It's my honor to be able to introduce to you the executive sponsor and lead of this work and the moderator of today's event, Dr. Brock Wright. Dr. Wright is the CEO of Shared Health, and in such a role, he is leading changes that will help to better integrate and coordinate health services delivery in Manitoba to ensure that we're delivering efficient, high-quality care for Manitobans. And one way that we can know if we're reaching that goal is to ask Manitobans themselves. So Dr. Wright will be providing important stewardship and vision as we move toward a provincial and strategic approach to integrating and incorporating the patient voice into the way we measure health systems performance in Manitoba. Okay.
Thanks very much. Is this working? Thanks very much, Sarah, and welcome everybody here. A particularly warm welcome to the patients who are in the audience and online. Delighted to have you participate, and I'm really delighted to be able to be involved with this initiative and be able to support it. So welcome to today's special forum on patient-reported outcome measures. As Sarah was saying, as many of you know, we're in the midst of a major transformation of our health system in Manitoba. Our performance on certain wait time metrics in particular has been poor relative to other provinces. And we also know that we have areas of real need in our system, like mental health and addictions, and like the need to work with Indigenous communities and leaders to address significant health disparities and inequalities. So we've got a lot of needs in the health system. The challenge for us is that we're already spending a lot of money on the health system. So our costs per capita are higher than most other provinces, and we don't have proportionately better outcomes to show for that additional expenditure. But the good news is that we have a real opportunity, and that opportunity is to begin to function as a much more aligned and integrated provincial healthcare system. I think as some of you know, the healthcare system until recently consisted really of the 5 regional health authorities that cover the geography of Manitoba. Cancer Care Manitoba, a separate organization that focuses on cancer planning and cancer services outside of hospitals. And then we had an organization called DSM, or Diagnostic Services Manitoba, that provided all the laboratory services across the province. And then there were some smaller but important organizations outside of those 7, like the Addictions Foundation of Manitoba, Selkirk Mental Health, etc. These are and were really good organizations, well-led, well-intentioned, but they all did their own clinical planning and they all set their own standards of practice. So what it left us with was a very disjointed provincial healthcare system, because patients don't just get all of their care within one geographic area of the province. And so when we looked at the whole landscape, we recognized that that was a real opportunity, an opportunity to align our efforts across the province so that we could first and foremost improve quality of care, improve access to care, but also do things smarter and more effectively, more efficiently, and free up resources in our healthcare system that could then get redeployed to areas of need like mental health and addictions, like Indigenous health, like reducing wait times. There's lots and lots of needs within the system. Now, governments decided to capitalize on that opportunity by creating a provincial health authority, a provincial organization that would work with all the other organizations to do joint planning and set standards. And they didn't create a brand new organization out of nothing. What they did is they took Diagnostic Services Manitoba, a very strong provincial organization, and they morphed it into something called Shared Health. And Shared Health currently is responsible for managing any provincial clinical services that should be provincially managed, like emergency response services, diagnostic imaging, laboratory services, etc. It's also responsible for managing any non-clinical services that are best managed provincially and not decentralized across the province. But the main reason for being for Shared Health is to bring all of our partners together, the 5 RHAs, Cancer Care, and the other organizations, to come around provincial tables and really work together on developing a clear provincial clinical and preventive services plan with a focus on clinical services and prevention, and to work together to set standards. We're also about to, and we've just been through a planning process. We now have a 5-year plan. I expect it'll be released to the public shortly. And we'll refresh that plan every year, so it's a rolling 5-year plan. And that plan will then be used to really determine what it is the different parts of the health care system should do. And more importantly, it'll talk about and reflect how we should all be working together. We're also in the midst of implementing a clinical governance model, because to make this work provincially, we need some provincial leadership, clinical leadership that can look across the entire province. And we're also working on an integrated approach to quality, safety, and learning. And so there's lots happening. Happy to talk to you outside this room if you have any questions about that. But the Provincial Clinical and Preventive Services Plan, the plan that we're all coming together to develop, is very much focused on meeting the health needs of the population, meeting the health needs of Manitobans first and foremost. And patient-reported outcome measures are one of the tools that we believe can really help to support and guide this work, because there's lots of metrics that are used in healthcare, but a lot of them don't necessarily tap into what the patients and our clients actually believe about the services that are provided. And that kind of feedback, those kind of patient-oriented measures are so critical to helping us plan the system and monitor its effectiveness. They provide us with important information about whether our healthcare services are improving the health status and the quality of life of patients. And this is an approach to measurement that's being increasingly used in other jurisdictions in Canada, and indeed other jurisdictions worldwide. So we've got some work to do, but I think we can catch up and we can perhaps surpass what other jurisdictions are doing in this area. So I'm really, really pleased to support this work, really happy to participate in the forum today. Appreciate the leadership of everybody who you're going to hear speaking. It is the right time for us to come together and really make PROMs the sort of a center point, a major area of focus within this broader transformation. Just going to introduce now very briefly They all have long CVs. They're all very impressive, this panel. So we'd be here all afternoon. So I'm just going to give you some highlights. Just first on my left here is Dr. Eric Boehm. Many of you know Eric. He's an orthopedic surgeon and professor of surgery at the University of Manitoba. He's also the director of Health System Performance Platform at the Center for Health Innovation. He will talk to us about how we use PROMs as part of the facilitated feedback to orthopedic surgeons to improve quality of care within the provincial joint replacement registries. Next to him is Dr. Lisa Licks, is a professor in the Department of Community Health Sciences at the University of Manitoba. She's got a long CV. She's a Tier 1 Canada Research Chair in Methods for Electronic Health Data Quality. She's director of the Data Science Platform in the Center for Health Innovation, and she's senior scientist at the Manitoba Center for Health Policy. And Lisa's going to talk to us about things we need to consider when choosing tools for collecting and analyzing patient-reported outcomes. Next, beside Lisa is Mr. Hani Al-Ubidi, who's a project manager with Immigration Partnerships Winnipeg, where he focuses on community engagement and is a member of CHI's Patient and Public Engagement Collaborative Partnership. In his 20 years of experience supporting ethnocultural groups, he definitely understands the importance of cross-cultural communication, and he's going to talk to us about how PROMs can positively impact doctor-patient relationships and improve quality of healthcare services. Then we have Ms. Jeanette Edwards. Jeanette is the strategic lead for community health, quality, and learning for Shared Health Manitoba. So Jeanette and I work very closely together. She has led the development of a Manitoba Quality and Learning Framework, which part of our transformation initiatives. And this framework is shaping the overall provincial quality strategy across all service delivery organizations. She's going to talk to us about how patient-reported outcome measures provide important tools to support continuous quality improvement and patient-centered care within health services delivery. And then towards the end, we have Dr. Ryan Zarchansky and Dr. Randy Fransu. And Ryan and Randy will be helping us understand and kind of the national and the broader provincial and national perspective on this issue. In his role as Manager of Client Affairs with the Canadian Institute of Health Information, CIHI, Dr. Fransu will talk about ways to build on and support national efforts to advance common approaches to PROMs in Canada. And Dr. Zarchansky, Ryan, is leading a provincial effort. He's got a long CV as well, but he is relevant to this discussion. He's leading a provincial effort and collaborative team to create an integrated real-time clinical data platform in the province. He will talk about how a provincial approach to collecting PROMs can be supported within this project. So once again, thank you for coming today, and you might hear from me later. And at this point, I'll pass it over to Dr. Boehm. Thanks.
Thanks very much. Thanks for coming and listening to us speak on this important topic. I must thank and congratulate Sarah Kirby for her hard work and incredible organization putting this together. Thank you very much, Sarah. Job well done. So I'm going to talk a bit about PROMs and how we use them in orthopedics. So my daytime job is doing hip and knee replacements, so I see lots of patients that present to me with sore joints that have failed non-operative treatments. So this example here, you can see the x-ray in the middle is a worn-out knee. And I can offer this patient two operations, either a partial knee replacement up on the top there or a complete knee replacement. Now, I have lots of good information about how long these two different implants might last. These are mechanical devices. They eventually wear out. So this is data from the Canadian Joint Replacement Registry that keeps track of all the hip and knee implants that we put in Canada and how long they last before they need to be taken out and redone. So I can tell this patient, if I give you a complete knee replacement, regular complete knee replacement, but at 6 years here, you've only got about a 2% chance or 1 in 50 chance of needing to have this taken out and a new one put in. But if I give you a partial knee replacement, there's a much higher chance, like a 6% chance, that by 6 years you need to have this taken out and redone. The information I can't really provide this patient is, does one of these work better than the other? Because they may say, well, you know, I'm willing to accept a shorter longevity if that partial knee replacement works much longer. So that's really this focus on patient-reported outcome measures and how much better is a partial compared to a complete knee replacement. So what are PROMs? Well, they're questionnaires that ask patients about, or people about, their health status as it relates to their quality of life. And it's gathered directly from patients without interpretations from doctors or anywhere else. If I ask somebody if they're satisfied with their new knee, they'll give me a different answer than if they're answering a blinded questionnaire. And it can measure physical, mental, and social health. So things like pain, fatigue, anxiety, depression, and so forth. These are all different things you can measure. Why collect PROMs? Well, I think they're important for many different areas. You can look at, for example, research. If you're developing a new intervention or new treatment, do you actually change that patient's or group of patients' quality of life? If you're doing quality improvement work, and I'll give an example of that later on in my talk, so feeding information on patient outcomes to providers to improve the quality of care that we give. You can also measure value. If you're trying to improve patients' quality of life and you've got a certain amount of money to spend, where should you spend that money? Doing hip and knee replacements, treating cancers, doing cardiac care, so forth. And also with clinical decision making, that example I just gave you, having better information to help patients make decisions around what type of intervention they may want to have. So I'll describe very briefly some experience we have here in Manitoba with our provincial joint replacement registry. We've had this up and running since about 2004. And these are the components here. So basically, patients are seen in the pre-admission clinic, which is the clinic they go to help get ready for surgery. They fill out some baseline questionnaires regarding specifically their hip or knee, as well as a general health-related quality of life questionnaire. We collect some information in the operating room on the type of implant that was used in the surgical approach and so forth. And then this information is added to information from the patients at the 1-year mark. So actually get a questionnaire 1 year after surgery, asking them important things like, are you satisfied with the results of your surgery? We ask them the same SF-12 and Oxford 12 scores again. We throw in some data from our medical records, length of stay, transfusion, and so forth. And we combine all this data and provide it to the surgeons on a yearly basis so they know how they're doing compared to their peers. So we get these yearly reports, you get your own data, you get your peers' data so you can compare yourself. This data is reviewed by a regional standards and quality committee. If you're different from your peers for 2 or more years, then you get a letter from the chair of the committee asking you to help the committee understand why you might be different from your peers. We also use this as a quality assurance mechanism for our central intake for hip and knee replacement surgery. Just some examples of the changes we've seen. So this is just an example of length of stay. It's almost hard to believe, but back in 2006, the average length of stay for somebody having a total hip was 9 days. We're now doing outpatient total hip. So you have your hip done in the morning, you go home in the afternoon. Just feeding this data back to surgeons and to sites helps them understand what they're doing. Here's an example of preoperative Oxford 12 scores. So this is the average preoperative disease severity score of patients undergoing hip and knee replacements. So 60 is the worst score possible and 12 is the best. So you can see there's really been no change in the preoperative disease severity over the time frame here. So this helps us understand that we're not operating on inappropriate patients with mild disease. Here's an example of somewhere where we've seen some improvement, and this is satisfaction. So it's a very simple question. How satisfied are you with the results of your surgery? Ranging from very unsatisfied to satisfied. And this data, again, is fed back to the surgeon. So we had a couple of surgeon outliers that weren't doing very well. So we actually sat down with them and went over their data and what some of the possible causes were. And some of them changed what they were doing. Some of them retired. So we actually saw an increase in the overall satisfaction rate following hip and knee replacement surgery. So it's quite satisfying to see this. I'm going to wrap up here with this little anecdote. I travel to Nicaragua once a year and do some charity work. We do hip and knee replacements down there. And the very first time we went down, we met an American team to kind of show us the ropes. And they brought down some greens to leave for the local Nicaraguan surgeons. Now, I'm not a big guy, but I'm larger than the average Nicaraguan surgeon. So they brought down some triple XL greens. So I said to Karen, watch her, I said, Karen, I bet you and I could fit in these greens. And sure enough, we could. So really, the point I'm trying to make is that if you don't measure, you really don't know what you're doing. So thank you very much. And I will hand over to Dr. Lisa Lex. Lisa.
All right. Well, good afternoon, everyone. Thank you so much for being here. Thank you for the team at the Center for Healthcare Innovation for organizing. Brock, thank you for being here to provide leadership as well. So we've heard the clinical perspective. Now I bring the methodological perspective. And my key message in my short time with you is that the development, the analysis, and the interpretation of patient-reported outcome measures really does require an interdisciplinary team, one that includes patients, that includes methodologists, healthcare providers, and clinicians, and those who will make decisions with that information. I work with patient-reported outcomes in the research realm. And we look at collecting and interpreting patient-reported outcomes so that we can better understand entire populations through large national surveys, for example, so that we can establish norms that enable us to do comparisons across populations. I also work with clinicians who are very much interested in individuals who have specific health conditions or diseases. They might be, for example, Crohn's disease or various forms of arthritis, where there is interest in better understanding symptoms, for example, pain and the patient's perspective around those conditions, or for specific treatments. And we've worked with Eric in my group for quite some time, looking at change, for example, in patient-reported outcomes in individuals who've had joint replacement. We can also use patient-reported outcome measures to help us with economic evaluations, to understand the cost-effectiveness of particular treatments, and interpret how individuals would place value on one's health or various dimensions of health. Now, in doing so, there are many, many different patient-reported outcome measures that one could use and collect information on. This is an example of one framework, the PROMIS framework, which was developed in the US in the early 2000s. And with patient-reported outcome measures, we understand that there are different attributes or characteristics of individuals that we can capture. For example, if we're looking at an overall assessment of general health, we recognize that it's comprised of physical and mental and social health or well-being. These are all important features or attributes of individuals that may change in response to health conditions or particular treatments that they have. And in fact, when we think about well-being, in fact, it's multidimensional, and there are various attributes that we'll want to gain in terms of the patient's perspective. But in doing so, we also recognize that, in fact, attributes such as pain, fatigue, when we talk about general health, these are not things or constructs that we can directly measure. In fact, they're all examples of things that are latent or what we cannot observe about the individual. So we can't measure them directly. Instead, we measure them indirectly through a variety of items or attributes. When we think about pain, for example, we might want to understand the severity, the episodic nature of it. These are all aspects or attributes of, in fact, latent variables. So a methodologist to involve is key because there are many different aspects to these latent or unmeasured constructs, and we want to be able to capture them and ensure that we're covering the range of attributes that might be relevant and how, in fact, they may respond differently for individuals over time and over space. And I'll elaborate on that in a minute. And equally, in doing so, the attributes of validity and reliability. This is honed into many of us early on when we've taken a course in measurement or in research methods, that what we measure, we want to be able to do so in a way that measures what we think we are. Are we actually capturing pain, for example? And can we do that reliably? And these are really elements of of what the research team that I work with across Canada refers to as exchangeability. So we want to think about being able to take any particular measure of pain, for example. Are we measuring the same thing? And can we do that with any of the measures? And exchangeability, of course, over time as well. So we think about individuals being able to respond consistently over time is really just exchanging one individual for another or one question for another. And this is what methodologists are involved in doing. So stated another way, and here's a visual picture for those who like that, an attribute such as physical function, we can't measure with just a single question, and we wouldn't want to because there are many different attributes to that. So for example, with physical function, we might want to ask questions about limitations on health in terms of a little bit of movement, a moderate amount of movement, or a lot of movement, for example. And these all reflect attributes of physical function. And so methodologists are interested in describing the relationships between these individual items and that underlying attribute or trait that we in fact cannot measure directly. In doing so, though, the major threats to us are the fact that we want to implement patient-reported outcome measures across populations, across individuals, but yet be able to compare apples with apples. But it's well known that attributes such as one's group of origin or ethnic group or cultural group, one's age cohort, as well as gender identification can all affect the ability to do comparisons, apples to apples comparisons. For example, work that my research team has done has revealed that when we think about Indigenous populations, their perceptions of well-being are not, in fact, the same as individuals who are from other groups within the population. And so we must recognize and honor that when we measure. As well, this idea of response shift, that in fact the way we use measurement tools can change over time as we have particular treatments, for example. So if we think about a single attribute, it can be a bit of a sliding scale in that we can evaluate ourselves, say, before a hip replacement, and then following that, when we look retrospectively at how we felt, we might say, wow, in fact, I really wasn't doing all that badly. So our conceptualization of the scale can change, and that can cause odd results where we would in fact not see, for example, real change, when in fact it's because the way people are using a scale has changed rather than the actual attribute of the individual changing. And again, methodologists are very important to help deal with these kinds of issues that arise when we ask patients questions. So finally, again, my pitch that methodologists and statisticians, and I have many on my team who have a lot of experience with patient-reported outcome measures, are focused on developing good measurement models so we in fact can measure the attributes we wish to. We can deal with measurement issues that arise, for example, as patients may make decisions not to respond. How can we encourage that so that we have robust and valid measurement strategies? Mode of collection of information is, of course, prime, whether we do that in an electronic form or more conventional forms, whether we have trained individuals to participate in those processes to ensure that there is an ability for all to answer and to understand the questions that are being asked of them, and how frequently we should capture that information in order to detect small or large changes over time in the way that patients perceive their own health and well-being. Thank you very much again for being here today, and I'll look forward to questions at the end. And with that, I would like to turn it over to Jeanette.
Thank you, Lisa. I certainly want to acknowledge Sarah's remarkable commitment to this topic and bringing us together and I'm hoping this is the launch pad to really move things forward. What I wanted to present to you today is now the system. How can we as a system support the implementation of patient experiences, patient-reported outcomes, and how do we actually apply this to a Manitoba perspective? Some of you may have looked at the KPMG report some time ago, and one of the comments was that Manitoba really has not had a definition of quality. We all use that word. We're now all talking about system transformation, but really this should always be about quality, quality care, quality service delivery. You'll also notice that what we have done as we've moved forward with this provincially is added the word learning. We all talk about quality, we talk about quality improvement, we talk about a culture of safety, and yet we still haven't really attached the learning component on how do we move forward in that culture. So this is a diagram. I won't go through it, but you can certainly all have access to it. And what you'll find is that we have taken quality and really defined dimensions of quality. In this framework, you'll see 10 dimensions. 8 of those dimensions have actually been adopted from Accreditation Canada, and it only made sense as we move forward with accreditation processes that our definition of quality is aligned. There are 2 additional ones, however, and I should tell you we had a lot of provincial engagement in developing this. And I'll quickly note the 2 additional pieces. One is workforce, and the second additional dimension Manitoba has adopted is equity. And I feel those are both important, and particularly important as we move forward around quality and safe service delivery. We heard loud and clear from public members, from staff at the front line, remembering quality is from board to ward, as some call it. Can you make this simpler? So we have applied the IHI quadruple aim and really put those 10 quality dimensions in 4 buckets or baskets. One of those is population health. Another is care team well-being. The third being reducing costs. In Manitoba, we're calling that how do we sustain the system? And I will point out the quadrant, patient experience. We need key enablers in moving all of this forward. One of those is certainly leadership and a shared vision. That is throughout the province, throughout every provincial health authority and service delivery organization. We need performance measures. Performance measures can certainly address all 10 of those dimensions. But again, I'm going back to an earlier speaker when Dr. Bone said, how do we know what we're doing unless we can measure it? So we really need to pause and think this through and think about systemic measures. We need the capacity to support improvement. So many of us working in the system over the years recognize that in the absence of defining quality, we also haven't had the supports at the front line or throughout the system that help us engage, and I will say involve patients in a meaningful way, but also staff. How do we move forward in learning? And the final enabler that we talk about in the framework is standards. How do we look at licensing standards, accrediting standards, and this also applies to our regulatory bodies. Very quickly, I just want to point out 2 of those quadrants that you saw in the overall framework. One of those is a population focus. So when we're talking about patient input, we also need to think along the continuum about public input. So oftentimes we have groups or aggregate groups of people, communities, who wish to also have a voice as a collective. So this is an important component as we're moving forward around healthy populations and a systemic focus. And the second dimension in this domain is equity. And I deliberately wanted to bring that forward so that as we're talking about PROMs and PREMs, patient experience, we must always wear an equity hat. That is equity in many domains, whether that be our Indigenous populations, our newcomer populations, but also our rural, northern, and remote. So again, in all of these measures, being flexible and adaptable to the communities that we're engaging. The other quadrant that is particularly applicable today is the positive patient experience. Our services must be client-centered, and in many circles, I would change that word to person-centered. But this is about partnering with clients, people, and their families. It's moving beyond engagement to real involvement. Continuity is a very important patient experience. And again, this is an important component as we're thinking about system change in healthcare. Everybody in this room is, has been, will be a patient, and we assume that we are working across the system as a system, not in component parts. So again, with PROMs and PREMs, we need to also think system. Patient safety is of paramount importance, and again, in this domain, we must include patients and families in really evaluating patient safety and being involved in recommended change. And the last dimension in this domain is accessibility. And I will remind you of the equity issue when we address accessibility. The last comment I wish to make is everybody has heard about the clinical plan. We are beginning to look at domains in which to start. But clinical governance, provincial clinical governments, will be key to us in implementing elements and priority areas of that plan. I want to ensure you and assure you that in all of the clinical governance networks that will be established, the patient voice, the family voice, and public engagement will be key as we move forward with future changes in the system. So to that, I'll hand it over to a colleague of mine, Hani, to give us truly the public perspective.
Good afternoon. I did not prepare any PowerPoint or brought any statistics or figures, but I thought to use what my friend Tom taught me and my dealing with the ethnocultural communities. It's when we talk about community engagement, we rather to do it that way, face to face, and just to humanize the process of connection. But I will, even though I said I'm not going to talk about figures, I'm going to throw a figure by 2036, our city, Winnipeg, half of its population will be nearly immigrant or second-generation immigrants. And the reason I'm mentioning this is the city is changing. And the people that we connect with or deal with also is not the same cohort or the same group of people. And for that purpose, we need to update our measures, indicators, and also our engagement strategies. I'm going to start to talk about the barriers to capturing the voice of the patient. And there are a number of barriers. Before I came here, I had a chance to talk to two people from who they consider themselves newcomers, both of which are originally from Africa. And I purposely took the time to talk to them about their perspective when it comes to capturing the voice of the patient for the purpose of measuring quality. And now, the word quality, life, and all that, it's very important when it comes to community engagement, and specifically for people who were seeking these type of qualities, leaving their homelands, coming to this country. So I took the time and I asked them, how do we capture the patient's voice and measure life quality? And they said, well, before you capture, basically, we need to create a space for the voice to exist. And for that, I would say, we need to keep in mind, if we want to create a program or policy, is to keep those people in mind. to create a space. So this is stage number one in terms of community engagement. I'm not here to talk about the measurement and how we measure it, but I'm talking about how do we create the space, safe space, for a person's voice to be heard. And then we'll talk about the technicality of how we capture that voice. We, through our work at the Immigration Partnership Winnipeg, which is a project that is mandated to identify needs and gaps in the integration process for newcomers to exist in the city. Our job is to create a welcoming, inclusive city. And I know this is a very broad vision. However, in order for us to create such a city, we have to create that space, safe space for people to express themselves and also to be able to connect with others without fear. And the word fear that I am mentioning here is for a specific purpose. Most of the refugees who come to the city, they left their places or their homeland because of fear. So when they connect with practitioners or healthcare staff, fear is still present. And for that purpose, for that reason, they would not be able to give you an adequate or a genuine answer. When you ask someone, how are you doing? And if you tell them, are you doing okay? If they say yes, really the yes not necessarily means yes. And that is because it's internalized fear that prevent them from being themselves to connect with the health practitioners. And for that reason, you would not be able to measure the quality that is connected to the service you provide. There are other barriers, such as belief system, religion, culture. That's all play in terms of preventing us from obtaining the right measurement in terms of quality of services. So, for example, some people, for some religious reasons, they would rather to go to a healer or a religious person than a doctor. And because there's a social stigma connected to certain disease or health conditions. So they would rather to disclose this information to people who they have that safe space and trust. When they come to people who look and speak differently, there is an invisible barrier already between the two. And that barrier would not allow you to capture that voice. So culture, religion, and also gender. If you see a family, and I'm not talking about all immigrants and refugees, but I'm talking about some people that I know, when health staff or a practitioner would meet with a family, usually the family have a spokesperson. So if you talk about individuals, you find usually the man of the family would answer on behalf of his wife or daughter. And that's another barrier. And so you would not necessarily reach that voice due to that cultural layer in this equation. So these are the things that I thought to highlight, even though maybe most of you know about these things, but these are the things that we think. In order for us to capture the voice of the patient, we have to create that safe place and to create a therapeutic alliance between the practitioner and the patient. And that therapeutic alliance would not be created just because we have a tool to measure. We need to have an engagement strategy where those people can come to a place where they feel, okay, we're represented. We're reflected into the policies that govern the service and the quality of service, and also the programs that are provided to us. We have an input, a real say in it. And for that reason, I really want to thank Sarah again, as the other presenters mentioned, but also I want to thank those 4 people sitting here from the Collaborative Partnership Committee, which I sit on. And thank you for your work. And also that stage 1 community engagement, I call it. It gave us the voice. That's why I'm here, talking about a large population in Winnipeg And I think this is a step number one in terms of engagement. I don't want to take longer, but basically, we're talking about immigration, refugees, immigrants. It's a very large topic. It's a very large group to speak on their behalf, or at least represent their voices. I'm looking here in the room, and I'm trying to see how many people identify themselves as newcomers. Raise your hands. I'm curious. 3, 4, 5. It's very good. Very good. I just want to close by saying that I have a quiz for you before I go back to my seat here. I don't know how many of you would know famous Canadian refugees that they actually contributed to this country. I don't want to walk away from here talking about refugees or immigration in a deficit kind of tone, but also I want to highlight their contribution. I have the answers. I'm not going to share them with you. But I will mention one of them, and the other two, we can share them later on. I was in Nova Scotia 2 years ago, and the speaker who came and spoke to us during an immigration conference, a newcomer, arrived in 2016, a Syrian newcomer. They lost everything, but he built everything from scratch. And this person he's the CEO of Peace by Chocolate. I think some of you heard about him and also tasted his chocolate. He has a plan, and the plan is he built what he lost of business to make chocolate in Damascus. He started it in Nova Scotia, in a little place, and his vision is by 2022 would hire 50 refugees and to actually help 10 members to run startups over the next few years of his business, which is very impressive. I thought to mention something that is very kind of grassroots level, but also I have two more, which is part of the quiz and the suspense. They occupied high levels in our society, and they contributed greatly. And for that, I would say thank you very much to everyone here, and have a good afternoon.
Okay, thank you very much to the speakers. We're going to open it up to Q's and A's. I just want to remind everyone again how they can access and ask us questions online. Okay, I'm going to try to remember this off the top of my head. So you need to text to number 376, hang on. It is on your brochure here, if you picked one up. Is my mic on? Can you hear me? Okay, all right. All right. You're going to text to 37607. Then in the message part, you're going to text CHIMB 622, and that's going to link you to this session. You press send, and it will link you to this session, and then you can ask questions, just to give you step by step. First of all, I'd like to open it up to any questions here before I go to the online questions. You're welcome.
That's Frank speaking.
We're around 20 minutes.
Okay, just to refresh everybody's memory, just to highlight a few things. Dr. Bohm, Eric talked about the important role that PROMs can play. And oh, sorry, we have a question. I'll just fill the gap later. Go ahead.
Good afternoon. I'm Thomas Baudry. My question, I guess, could be for all of you. You were talking about Indigenous engagement, which is really good in regards to PROM. But the question is how are you going to, since we're trying to make it Manitoba driven, how are you going to look at the jurisdictional issues between the province and federal authority of looking after our medical, mental, physical well-being? Because right now it's not. And how are we going to collect that data when the province says that we don't need to collect it because that's the jurisdiction of the federal government that needs to be collecting that? So how do you look at PROMs addressing that issue?
Maybe I could just start off making a couple points because it kind of relates to the broader health system transformation. And the first thing I would say is that we are, sorry, are you getting a mic? We're approaching as I was mentioning before, we're approaching the provincial clinical and preventive services planning, developing a plan. We're approaching that on the basis of what is a plan that can best meet the health needs of the population. And for that planning purpose, we're really ignoring jurisdictional issues. We're ignoring the boundaries between RHAs. We're ignoring the substantial challenges between federal and provincial government relations, which you know all too well, because we really want to base it on the health needs of the population. Now, we're not naive. We know that once we develop a plan and we figure out how best to deliver mental health and addiction services across the province, how best to deliver surgery and anesthesia services across the province, that when we turn to implementing that plan, we're going to have to face the realities of these jurisdictional issues, including the federal, provincial, as it relates to Indigenous. Through the planning process, we've involved a lot of, we've certainly met with and talked to quite a number of different Indigenous representatives. We've had Indigenous representatives participating on all of the planning teams. We've had a table focused specifically on developing a framework for how to engage. Dr. Catherine Cook and Avis Gray, who's an ADM, co-led that team. So it's very important to us that we hear the Indigenous voice. And I just want to say quickly that we're approaching it on the basis that we're not here to do the planning for the Indigenous communities. We recognize that they're wanting increasingly to take more control and responsibility over their own health system. So we're approaching it more as a partnership. You know, we can't plan in isolation of knowing what the Indigenous communities are planning, and they can't really plan successfully without knowing what the broader health system is going to be and how best those connect. So does anybody else want to comment?
Thank you so much for that question. There's also a piece of work led by Dr. Marsha Anderson, I believe you know Marsha with Angamazin, and deliberately looking at and working again with digital health and others at race, ethnicity, and Indigenous indicators. You're absolutely right. We have broad aggregate information, such as the report just released from the Manitoba Centre, but we must do a better job in not only engaging our First Nations people, but having the correct information.
Yeah, Jeanette's point's really important about really having that data from a population perspective around who is Indigenous, and also within our own health system and the staff. You know, so that continues to be a challenge.
And I'll add to that, just in terms of recognizing, as I mentioned in my talk, that Indigenous peoples may have different perceptions. Their conceptualization of well-being, it's well known that we need to be sensitive to that in terms of measuring patient-reported outcomes. So, for example, the spiritual dimension of health is well known to be very prominent in terms of the descriptions of well-being of Indigenous peoples. I'm heartened. I was just working on a book chapter, and that was a component of describing the work that's occurred in the measurement of health and well-being of Indigenous peoples. I was heartened to see I was doing an update, and in the past 6 years since I wrote the original version of this chapter, there's been tremendous work that's been done in Canada, as well as in Australia, for example, on measures of Indigenous health and well-being that can be used in the patient-reported outcomes environment. And certainly it would behoove those who are leading the provincial strategy to take recognition of, take note of that, and also invite experts in those areas to participate and consult, and I'm sure that will be the case. Others who want to speak to this issue?
Yep.
Miigwech.
Go ahead. Yeah.
Hi, my name is Kathy Woods. I am co-chair of one of the SPORE unit. It's called Solve CKD, and we use a lot of. Our whole organization is based on patient-orientated research, and one of the things that we found as we made our way through this process is there is an education process that has to take place for researchers and clinical people and all of the scientists in terms of trying to understand Indigenous focus and how we work and what happens. And so we've created this learning pathway as part of our training, and we're urging all our researchers and our doctors and our renal specialists and everything that we're doing. We're urging them to take this learning pathway, which is a pathway that includes Sanya's training, includes many different models on working to understand what it's like to work within the Indigenous communities. I'm the patient lead right now on a screening project that's happening in Manitoba, working with Dr. Paul Commenda over at Seven Oaks on this screening project. And one of the other things that we found in terms of trying to get a patient voice is that we found that it was easier on all our committees and everything to have more patients than staff or people making the decisions. That if the decisions are going to be made and the decisions are going to impact the patients, that we always have, it's not really a quota, and I don't like numbers, but we always have more patients than clinical and researchers and that on our projects. And we also found that when the researchers were going in and asking questions and doing their randomized trials and all of that, that it was far better to have a patient, someone that has had kidney disease or someone who has experienced, someone who's been a caregiver, for them to go in with the researcher. And then we found that the feedback from the patients was much more open, and it's about creating that cultural safety for everyone to be able to do it. So if you're interested, just look up Solve CKD. We're doing a kidney check project here in Manitoba, and we've got we're working with CIHR on their training entity, because we're trying to roll this model that we have. We're actually working with John McGavick on through Diabetes Action Canada on the expansion of the model, and we've got lots of little things in the fire to try to keep going in that.
Well, thank you very much. Thanks very much for sharing that, and certainly encourage people to reach out if they'd like to learn more about that approach, because it certainly sounds very relevant to what we're talking about today. Yeah.
Hi, my name is Dylan McKay, and I guess I'm a researcher as well. I'm based at CHI, but I'm also a patient, and so the perspective of capturing patient reported outcomes. One of the things that I didn't particularly, they were sort of touched on across the application, the presentations, was active versus passive capturing of the outcomes. And as Mr. Al-Ubidi mentioned, that the safe spaces are important, but if they maybe someone can discuss how the balance of those, right? If you have passive capture, then people like me will respond to those because I'm really interested in the topic. But if you're not aggressively going out to get the outcomes, and the people who don't answer are people you don't get measurements from. And as Dr. Bohm mentioned, then if you don't measure it, you don't know it's there. So maybe some people can discuss how the balance of those things, and if you can have active, passive, so where you capture patient-reported outcomes, and it's not an additional burden on the patients as a topic.
Anybody want to respond to that?
So I have the mic in my hand. Yeah. What I meant by safe space is, you see, there's a larger group in our society is just trying to establish their lives in Canada. And part of establishing their lives is not only the physical space that they need, but also the empowerment space that we're speaking about. In terms of balancing those two dynamics, I think once you represent those groups in higher level, let's say, programs and policies, they would be encouraged to have voice. and their voices can be captured or harvested, whichever means that you would create. But first, stage number one is creating that space where I, as a newcomer, if I walk into any place, I see some former or seasoned immigrants occupying spaces in society, I will be empowered, I'll be able to speak. And there, for you as a researcher, you would capture my voice. That's what I meant by safe space. Now, I don't know, I'm not a researcher or I don't know about measurements in terms of technicality, but I can tell you one thing. Some people, some newcomers, they come from places where it is dictatorial regimes that they lived under, and the health system is just one piece part of a structure that is state-controlled system. So when I, as a patient, go to you or to any doctor, I have that in mind, that you are just an image of that authority. And for that purpose and reason, I'm not going to disclose what I actually should be disclosing. Confidentiality is another piece, and there are so many other layers. I don't want to take most of the time here, but basically, we need to look at the connected dynamics when we look into voice and how we capture it.
Thank you very much.
Good afternoon. My name is Karen Thomas. I actually work with people who are survivors of moderate to severe brain injury. And my enviable job is to try and help them move back home after these injuries. We know the primary indicators of health generally is not the pills, not the surgery, it's socioeconomic status. After these kinds of injuries, people don't have jobs. Anybody who has a low socioeconomic status has less living conditions, less access to communication tools. They may not have a telephone, very difficult to engage, and their issues are no longer health issues, but social issues as an outcome of a health adverse event. How does PROMs incorporate the social outcomes? I believe, Dr. Licks, you were talking about PROMIS, the 3 areas, and the social was very tiny at the bottom, but when you ask people who had these serious events, what's the most important thing? They say the loss of my home, the loss of my job, the loss of my family. How does PROMs address those issues? Thank you.
As my background's rehab, but also community development, and absolutely, and I will turn it back to research, but a PROMs is a tool, and this is a huge opportunity for us to come together and explore these very issues. But I also have to say that we also need to be very careful about who may not be included in some of our standardized ways of collecting information. And I think there's another point that I do want to make, and I've done work in the North, just came back from Northwest Territories actually, and the lesson learned is person involvement, which I feel is more than engagement. Must have many forms. And what we really need to do is ask ourselves, what do we need to know? Where can we get input and modify the approach? So I hear you, and I think we have to be careful to not be prescriptive, but also look at the flexibility. My last comment on this is ensuring that we are here really wearing a health system lens. But the question you're raising is a health lens. And here's where we need to partner with other sectors. So including housing, family services, social services, and others.
If I could just while it's being passed to Lisa, if I could just pick up on that for a second too, because it is a really important point. And I think where PROMs comes in is it will help us as we continue to transform the health system and continue our ongoing planning. PROMs will help inform us around what's working and not what's working and what's not working. Because to get to your issue, we're spending $6.5 billion a year in Manitoba on health services. I'm not sure what percentage of that is of the provincial total health budget. It's in and around 45%. It was growing at 5.8% a year, which is huge. If we continued to grow at 5.8% a year, that $6.5 billion would double in 12 years. If you think about it, that would crowd out spending in almost every other aspect of government, education, employment, et cetera. And we know from, I've read studies, I don't know how scientific they are, that the health system itself really only contributes about 25% to the health of the individual. Maybe 15% is your genetics. The rest are all things that can be adjusted, influenced. It is education, it is employment. So I think to the extent that PROMs helps us figure out what we should and should not be providing in the health system, that indirectly certainly has an impact on the resources that are therefore available to support other important determinants of health. Lisa, did you have a comment?
Yeah, well, the only thing I wanted to add was, and you pointed out that that when we talk about health and well-being, there are different dimensions of that. And so as a provincial strategy moves forward, a high-level framework that acknowledges the different attributes or components of health will be part of what's initiated. So recognizing that the part of the desire to have a provincial strategy is to recognize that it's not just about the absence of particular physical symptoms, or it is in terms of health, but that there are social and spiritual and mental health components to that as well.
We just have time for 2 more questions, but then there will be time for more questions in about 20 minutes. But we just want to give our last 2 speakers.
Yeah, we're going to do another session of Q's and A's, and I wanted to also tell everyone that we will post all our Q's and A's on our website, chimb.ca, within 2 weeks of this session, because we probably won't get to every one of them. But I just wanted to ask a few that came by Poll Everywhere. I think this one might be directed to you, Lisa. How do the mental health conditions of the patients affect validity and reliability of the PROMs, and what should be considered to get accurate PROMs in such a situation?
Okay, so I spoke in one slide about the fact that we measure in heterogeneous populations, and we do that in order to reflect the full population, but we recognize that various attributes of individuals can certainly influence the comparability of questions. So methodologists are certainly interested and involved in evaluating the validity of a measurement model, for example, in different populations, and that's the way to do it, is to ensure that someone who can talk about, are we actually comparing apples and apples, and do some of that validity assessment is an important component of developing a strategy. That's why I said a team and an interdisciplinary approach is really important to that, and to reflect the most current research that's available on those topics.
Okay, and we'll do one more online. So this is kind of 2 questions I think that are related. How are we going to decide where we start? And how does the public or patients know which areas of healthcare need their voices? Kind of a similar question.
Where do we start? Any ideas there, Brock? That's almost a philosophical question. I think there's a lot of different aspects to our healthcare system. Brock's talked about a lot of them. Things that I see relate around access to care and differences in sociocultural background and so forth. I think that's very important. And I think, it probably behooves us to try to understand where the biggest challenges are, and where are we spending or expending a lot of our resources, and are we making differences, the intended differences that we want to achieve. And those are probably the areas where we should be focusing our measurement efforts so we can improve what we're doing. And to come back to a previous question about, the different outcomes, the example around somebody with a head injury or brain injury, and what is important to them is very different from a patient of mine who's coming to see me because they have pain and they can't walk. Right? So I think really understanding what's important to patients and having those relevant outcome measures so we can see if we're making a difference or not by providing care.
Yeah, I would just quickly add that I think there are lots of opportunities to move this forward sooner rather than later. Dr. Bohm has really provided tremendous leadership in the area of orthopedics to introduce PROMs. And he's utilized what we call a provincial standards committee to affect some of that work. And the good news is we're now going to be provincializing all of the standards committees in surgery or in broader surgical disciplines and mental health, et cetera. So I think there'll be a vehicle there to pivot off some of the work he's done in his standards committee to introduce that same sort of analysis. Because that feedback to clinicians about their performance that he talked about, that having that kind of PROMs information to help patients have a more informed choice about their options and their procedures, that's really applicable in all fields of medicine. It's not unique to orthopedics. So I think there's a real opportunity there. And I do think we do need to reflect on what Hanny said, because that's a pretty remarkable statistic he threw out about 2036. And we need to really understand, how do you create that safe space? Because we don't want to just measure for the sake of measuring. If the information we're getting isn't really what people are truly feeling or comfortable saying, then we're absolutely going to have to address that and think creatively about that, or our measurements aren't going to be worth very much. So I think there's lots of opportunity to move forward. What I'd like to do now, I'll come to you first in the next round of the questions. Okay, so just hang tight if you could. And we'll spend a few minutes now hearing from who's going up first? Hearing from Randy and then from Ryan around some of their work and some of their perspectives, and then we'll come back and we'll do another Q&A. Thanks.
Beautiful. Thanks, Brock. So just want to add a few words from the sort of national perspective. So my name's Randy Francoux. I'm a longtime Manitoban, but for a couple of years now I've been working as the Manitoba liaison person, essentially for Canadian Institute for Health Information. And we've got a number of initiatives going on in the realm of patient-reported outcomes and patient-reported experience measures as well. So on the PROMs side, the focus is currently on hip and knee. We are led by a fabulous advisory group chaired by actually Dr. Bohm. So there's a strong Manitoba connection even at the federal level there. So the Canadian Joint Replacement Registry is that focus that's been going for a while, and that's what we're building on. CIHI, as it does, tries to develop national standards in terms of what instruments get used and which data gets collected for different kinds of things. And so in this space, we've tried to establish the national standard as the EQ5D, that's one of those measures of quality of life, and the Oxford Hip Scores. Or knee scores, depending on what patient you've got. So CIHI has national licenses for these things and tries to encourage everybody to do these, but it's not something we can mandate. So CIHI sets a standard and encourages provinces and territories and other health organizations to use them. And so, for instance, in Manitoba, the great group that Eric worked with has been using the SF12 from the get-go, and we're trying to nudge them over towards the EQ5D because that's what the national and, in fact, the international standards are going to be using. So it's a process of, nudging over time and getting more and more people on board. There are projects going on in a number of different places. I'll show you a map of the country in a minute. But it's pretty exciting that about a week from today, there's an OECD report coming out that's going to feature results from Manitoba and Alberta as among the Canadian data representing Canada, even at the international level. And there's work going on in a number of other areas with those groups as well. So here's the picture across Canada. So the darker the teal, the closer you are to the CIHI national standard in terms of which data you're collecting and such. So BC is working on developing its whole provincial program, and so we're happy to know that they have decided to adopt the tools that are recommended from CIHI to meet the standard. Alberta's got a really strong system, but they don't use the exact tools that we are hoping for them to use, the Oxford Hip and Knee Scores, so we're working with them to do that because they've got a long history and a lot of data. We just want to be able to make the tools comparable so that we can best learn from each other. In Manitoba, as I mentioned, we're in transition. They've been using the Oxford Hip and Knee Scores for a number of years, but the SF12 we're hoping to transition to the EQ5D. Ontario is starting a provincial-wide pilot, and they are using the tools as well from the CIHI standard, and Nova Scotia is too. So we're starting to get there, and hopefully we'll be able to get everybody on board and using the same tools because that's really the way to be able to compare things. And one of the benefits of the national picture is it can show pockets, and you can see places where you can learn from others, where there's populations that are similar. And there's a lot of fabulous things happening in Manitoba on this front, and we can learn, from different service delivery organizations, and RHAs can learn from each other. But, the context of Northern RHA, for example, in Manitoba, has a lot less in common with the southern parts of the province than a lot more in common with northern Saskatchewan, northern Alberta, northwestern Ontario, northern Quebec. And so that's where the federal or the national pan-Canadian picture we think has a lot to offer as well. And so we want to really be working on encouraging all of our partners to use the same tools so we have that apples-to-apples comparisons. The OECD has a number of things going on in the realm of PROMs and PREMs. There's some generic ones and there's some condition-specific ones. In the condition-specific things, there's the hip and knee replacements. That's the most advanced. There's a breast cancer group that's getting going as well. There's a mental health and addictions group that is starting to have things going on. And then there's another group starting on patients with multiple chronic conditions, because that, again, can be, you might develop specific tools that are relevant for cancer patients or for brain injury patients or, the particular examples. But there are a lot of patients who experience multiple of these kinds of events and experiences, and so we want to be able to do that as well. And then finally, there's a piece of work going on in Ontario about PROMs for stroke patients as well. So there's lots of development, there's lots of niches going on. What we're always trying to do at CIHI is to bring things together to try to make the data and the system as responsive as we can make it to all Canadians, coast to coast to coast, and across all groups that we have going on, that we see pictures on. So yeah, sorry, a little animation there. So the things, again, that we're trying to do is make sure everybody's using the same tools and then expand beyond the existing ones. Hip and knee, as I mentioned, is the most developed one, but there's a number of others on the way. Making sure the data is relevant and useful. So again, this is about making sure we have the right tools, making sure that the right spaces are created to gather the information, using those tools so that we can get them there. And then using them with other things. One of the sort of mantras of CIHI is, we always say, be very careful using one indicator in isolation. Even indicators that are really well developed and robust and good usually have to be fit in with other things, other measures, other contextual factors, sometimes even qualitative factors, to really understand how that fits into the picture and how the silos and the different parts of organizations get together. So health systems don't usually respond to a single indicator, and we think they shouldn't, except in very specific areas. We need to have a broad base of data to make decisions on. And then also considering that we want to make this as easy as we can so that adoption is virtually universal. So, instruments that have a heavy data collection burden and rely on specific technology and stuff are not as favored as things that can be done more easily and more widely across things. So we're trying to use all we can in terms of technology to get the data as easily as we can, knowing that as long as that's done with valid instruments, we'll end up with better data that's more comparable across the country. So that's all I'm going to offer for now from CIHI, but happy to take more questions, and maybe now I'll turn it over to Ryan.
Thank you very much. I'm Ryan Zarchansky. I'm a critical care physician and hematologist at University of Manitoba and Cancer Care Manitoba. Probably those two specialties, hematology and critical care, were the most culprit in collecting physiologic and laboratory-based data where the patient voice was marginalized instead of at the center. We cared in the ICU whether that blood pressure was in the right target or whether someone's organ worked better or not, perhaps if you lived or you died. But we really just, we mostly cared if you survived the ICU. But you could have languished on the ward and died there, or been in agonizing pain for the next 3 months, or been destitute and not had resources to care for yourself as an outpatient, and we didn't see that. Likewise, in hematology, we saw the hemoglobin, or whether the cancer went away or came back, but how the patient did wasn't really reflected at first in the specialties. But we changed based on that need. It takes a lot of change to manage the patients appropriately, to manage us appropriately as taxpayers and as patients in those dual roles. And one of those changes has been the health system, and Brock and Jeanette and others are leading that. Part of that is data. The need for data has never been greater. We still care about the blood pressure in the ICU. We still care about the hemoglobin. But how someone is doing now, what outcomes are important to them, are the outcomes that are important. Because we are the custodians of the healthcare system. We own it. We pay for it. The outcomes achieved ought to be the outcomes that are important to us. Some of us already knew that. Harvey's up there if he's still there. He's been doing this for his career, Harvey Chachanoff. Many in orthopedics, Eric has been leading this. Lisa's been making sure that the outcomes that are collected, even if they're patient-reported outcomes, they're high quality, they're validated, they're standardized. Those are all really important. But still, many populations were left in the dark, right? They weren't captured. PROMs wasn't really, they weren't adopted by all specialties. They're still not adopted by all specialties, and a transformation was needed. We have lots of data in Manitoba, absolutely. Databases they run rampant. In Perry Paulson's there from Digital Health, who has a large leadership role in maintaining these for the province. Laboratory, imaging, microbiology, whether you got admitted to the hospital or not, whether you went to the ICU or not. specific mental health databases, specific nephrology databases, orthopedic surgery databases, and most of these never really talked together. They were linked in a computerized way for specific functions, but that was on a day-to-day or a need basis. But we still didn't know who was getting sick somewhere until they came to hospital, even though they were getting blood tests. We didn't know we didn't know how many people were waiting for a certain test or had a bad outcome unless we queried the database. It wasn't really available to us. And we thought that we could do better. And so we are partnering in the province to coordinate all of the clinical databases, the ones that you collect every day, the labs, whether you're booked for surgery or not, whether you're in hospital, you got a certain drug as an in or outpatient. Our vision is to coordinate all these databases, link them by code, and output them based on your need, whether you're a health practitioner and you need to care for a patient, whether you're a health policy person and you need to understand how a population is doing, or a health administrator and what's going on in your hospital, or perhaps a clinician scientist where you're evaluating something on a real-time basis. And so we're partnering with the province of Manitoba, and Nathan Hoopner's here. This is supported by the Minister of Health, and Dan Skwarchuk is the Associate Deputy Minister who's leading this initiative with us. Under the leadership of Perry Paulson, again from Digital Health, facilitated by Brock Wright and many others, Cancer Care Manitoba, the Centre for Healthcare Innovation, the universities you can see, also supported by a federal grant. We're going to demonstrate to us as taxpayers, to the regions who govern health, to the province who organizes it at that higher level, that if we use these data more appropriately, we can understand the value of our healthcare systems. We can optimize outcomes that are important to patients while saving money. We can predict a disease in individuals and intervene before their lives become or take some direction that is no longer remediable. How does this fit in with today? Well, one of these important databases that don't exist provincially or systematically is a PROMs database. Eric's been doing this. This is his career in orthopedic surgery. In cancer, there are many patient-reported outcomes collected, but again, siloed off in malignancy databases. In nephrology, there's certainly great leadership in patient-reported outcomes. How is that reflected in a provincial database? It's not yet. And so by having an integrated, near real-time clinical database that has all relevant health data in it, including patient-reported outcomes, we can, as patients and as taxpayers and as custodians of the healthcare system, understand if the changes that we are making, if the inputs, the expenditures that we're incurring every day are meeting the needs of patients, are reflecting the outcomes that are even important to patients. And we can do this at a provincial level now with such a database so that jurisdictional barriers are broken down, like we talked about, that was raised. So that this can be linked nationally, like Randy talked about in the initiatives going on within Canada. This will take a vision. We have this vision. This will take commitment. We have the commitment of the government, of health regions, of many clinician scientists, of patients to let us know how they want such an integrated data platform to take shape and what needs it has to meet to fulfill their expectations. And we're doing it in the context of 3 demonstration projects. I won't go into the specifics of these 3 demonstration projects, but the concept is that in 3 different domains, we're going to use health data 3 different ways to achieve 3 different outcomes that are important to patients, thus demonstrating that an integrated clinical database is worthwhile and that we should expand upon it and make this just how we do business, to incorporate all the health data within the province of Manitoba. We're going to do this in transfusion and hematology, where people undergoing major surgery are going to receive a cheap drug and hopefully will save blood. and we'll understand the patient-reported outcomes that have been incorporated into that trial, which are quality of life and days alive at home, outcomes that have been fed back to us by the patients themselves in our own patient partner groups, of which Thomas in the audience is one of them, one of our patient partners. In Captain, this is an oncology evaluation of a program where patients are navigated electronically using real-time data, so they can see people with a new diagnosis of cancer. What's their benchmark? When are they going to see the doctor next? When will they get those tests organized? When are they booked? And all the results of them. A patient access portal. Can you imagine that? We still don't have our ability to receive our own information as patients, and this is something that will be integrated into that project on a demonstration basis. And Home First is a program where patients are, this is led by Paul Commenda, sorry, the one in Captain is being led by Marshall Peets in Cancer Care Manitoba. And so the Home First project is evaluating at a systems level the ability of data to predict when a patient will need dialysis, and then to educate that patient, their caregivers and their communities about home dialysis modalities. Because home dialysis modalities have, one, better outcomes, and two, inexpensive, and then all these patient-reported aspects around that. That is, patients in wherever in Manitoba, but particularly up north, First Nations reserves, don't have to uproot their lives and come to Winnipeg to receive dialysis care, and they can do this care with better outcomes in their own home. And so all this is being done with real-time data. All of these are using data in different ways to study health interventions, to evaluate programs, to improve the quality of the system and use data for surveillance. All of them involve patient partners, and all the patient partners have embedded the PROMs, the patient-reported outcomes, so these health measures reflect their needs. Not my needs, not Eric's needs, their needs. They all will hopefully demonstrate improved outcomes as they've been defined, and they all will have economic evaluation, so we can understand some of the value-based decisions, the economics of the investments made. This is an opportunity. I mean, Sarah's provided incredible leadership to get this PROMs initiative off the ground, and I really do commend you to that. Brock is executive sponsor, and he's really committed to seeing this roll out on a provincial basis. This, like the initiatives that he and Jeanette are leading to transform our healthcare system, is a transformational use of data. We can embed PROMs to address Manitoba's priorities that reflect the outcomes that are important to patients. We can leverage existing data sets to help do this, and then we can incorporate new data sets that are driven by patients, for patients, that reflect the needs of patients. Such a system like this will help make our healthcare system sustainable. It'll help incorporate value-based decisions, whatever the value is that we define, into our evaluation of programs. We can scale this. We can start out at certain specialties, work to a provincial lens, and we can do this with patients and for patients. Hopefully the idea is that every outcome that are important to patients are the ones we make decisions on. Hopefully this creates a system where every patient experience informs the next. Every patient outcome is systematically captured. And so we don't have to wait for a research intervention or a clinical trial to understand if this is better. Every patient outcome that happens on every single day of every single visit informs the value and then the decision-making the next day in our system. And so this is the opportunity created. I just wanted to introduce that opportunity before us and how it could be used to incorporate PROMs in these three demonstration projects to then be scaled up at a provincial level. So thank you for that opportunity to talk about it, and thank you, Sarah and Brock.
I'd like to comment on a couple of things Ryan said, but let's take a couple of questions first. You were very patient. Okay. Thank you.
Sorry. Hi, my name's Hannah, and I'm the Health Equity Lead at WRHA. And so I just wanted to thank you for your comments, Hanny. And part of the conversation that I heard, and it's sort of follow-up to the time before, is about how we can do sort of health equity promotion better, like at all levels, and then also thinking about, and in this case, I'm seeing some connections for PROMs for sure. And what I wanted to do is more comment on a tool that or a suite of tools. It's almost overwhelming, the number of tools from a CRHR project that we've heard about in Ontario and BC called Equip. And it's about equipping healthcare practitioners with the tools and resources to promote health equity. So they make a strong kind of call for making social connections or connections to social resources, right? And that idea of working better cross-sectorally. But they also include a very strong trauma and violence-informed care approach. And they've got questions in some of their tools about, did we treat you with, or do you feel like you were respected? And an emphasis on building trust and safety with clients in that process is sort of like what you can do all the way through. So I just want to make a plug for those comments and those tools that we've got workshops at the WRHA that we've been trying to do with staff to just more embed that. So thank you very much, because I really hear you.
Okay, thank you. Do you have a question?
Hi, I'm Gail Restel. I'm from the Department of Occupational Therapy at the University of Manitoba. I'm wondering if you could comment a little bit about qualitative methodologies in terms of outcomes and things like journey mapping, arts-based methods, just to gain experience from diverse individuals around that. I've heard a lot about quantitative measures. I'm wondering about those qualitative measures and their potential for hearing the stories of very diverse populations who might not be so engaged in quantitative surveys.
They're all fighting over the mic.
Well, Gail, thanks. I think it's a good point to make. I think you probably got a fairly quantitative audience up here, but I think it's a good point to make. I think in the line of measurement, too, the qualitative piece has informed often the development of new instruments where we may be missing particular domains or dimensions. That's my experience with it. You'll see it as a broader tool to collect more in-depth information, and I think that that's certainly an accurate assessment. But where we may be missing particular domains or perspectives on health and well-being, that's another role that the qualitative methodologies can take. Anyone else want to add?
I love how the statistician in the crowd jumped to that answer, so I love it. But it is a really important comment, and I think what I've learned by engaging and partnering with patients is that we may have come with a certain lens about the outcome that may have been more quantitative, and I might say to Thomas and the others that I'm really interested in this therapy that works in septic shock, or I think it might work, and then Max says, yeah, but I want to talk more about PTSD, Ryan, and so the voice of the patient is immediately captured within the planning of the research, and it definitely has set the tone and the direction for what we do every day. Can we bring this onto provincial level? Maybe. Do we need to? I don't know. Probably the answer is yes in some domains, but we'll have to work with the patients and the stakeholders to understand how we do that. Because you're right, we're missing those important stories often. But by engaging with patients as partners, I see now personally, and among my colleagues as clinician scientists, the value of that, and it is being translated into our research now daily.
Jeanette, and then we'll take another question. Yeah.
A great opportunity, Gail, so I open that to you. And I think we need to really step back and think about how far we've come, but where we need to go. Patient advisory councils started picking up all over the place, and we have some representatives in this room. Have we evaluated those? And I say that from a qualitative perspective. And I also feel that we need to pay attention to engagement of our public, like our Indigenous folks, and go back using qualitative tools to talk about, have we actually moved to the point of real involvement? So I think it's an area we need to explore.
Okay, question there.
Hi, Thank you all for your comments today. I'm Melissa Kalbeck. I'm an occupational therapist at HSC with the MS Clinic. And I'm a clinician who delivers therapies. And when we have time, quality time to see people and build relationships, some of that response shift is part of what we're looking to establish, right? And we also have, I think, a little more time to work with people and families and communities at large. But measuring response shift as an outcome is difficult. So I was wondering if you could speak to how, and I think it does relate to quantitative and qualitative data coming together.
Yes, and there are new, so as a statistician, I view response shift as not a good thing because it's a form of measurement bias, but the clinicians that I've worked with have been conditioning me to view it differently as a positive because, in fact, we do want to change how people may use scales or interpret scales. And also appraisal methods, which use a more qualitative approach as well to understand how people may appraise a scale, just how they may use it, are the new development in the response shift literature. So there's just been a little bit that's come out in that, and I can certainly share some of that information with you. So thanks for that comment. Yeah, that there are certainly very different perspectives on response shift, and that's important as the field develops.
Just as we're waiting for more questions, just a comment that I'd like to make and a question, and it was partly sparked by what Ryan was saying. You know, when I reflect on the past, something that, and I know you gave a lot of shout outs to people. Hugh Goldie's in the audience as well, and Hugh was very involved in total quality management, continuous quality improvement. And I remember when that was first introduced really to the healthcare sector in 1990, and it way preceded, I mean, it came long after it was introduced in the manufacturing sector and then also in other parts of the service sector. And of course, one of the major shifts in thinking with total quality management, which then became continuous quality improvement, which now most people know as lean management. One of the underlying tenets was the importance of looking at quality not only from the provider's perspective, but also from the client or patient's perspective. And that sounds like an obvious thing, but I can tell you it has not been an easy sell because we're dealing with a medical establishment with lots of professionals who really believe that they know what's best for the patient, and how can a patient judge what is a quality surgery or a quality chemotherapy? You know, they're not experts. We're the experts, so we should dictate what the quality measures are. And it's been a long journey over the last 30 years, and we've made some real progress. There's lots of examples on the stage of progress that's been made, but we're nowhere near where we need to be. And any other business that wasn't focused on their customers' outcomes and their customers' experience during the process wouldn't be in business, you know. But in healthcare, as you can all understand, there's reasons. And I don't know if one of you want to talk at some point about the difference between PROMs and PREMs. I don't know too much about it, but PREMs are patient-reported experience measures. Is that something we're interested in as well, or is the main focus PROMs? Yeah.
Yeah, so I think certainly from a CIHI perspective, both are important, and Manitoba is actually quite a leader in the patient-reported experience measures as well. So I guess 2.5 years ago, CIHI launched the National Canadian Patient Experience Reporting System, which is, again, meant to be pan-Canadian to collect data from coast to coast to coast. Manitoba was one of the first jurisdictions to come on board and has a pretty extensive and well set up system for capturing patients. So I think it's 10% of all patients discharged from hospital get sent the survey. And in some regions it's done on paper, in some regions done electronically. We're trying to make sure that that mode doesn't affect things much. But that kind of work is happening across the country as well. And it also contributes to what's going on, because outcomes aren't the only thing, right? How you got there is also relevant, and that's one of the things that PREMS captures.
So do you have an online question? And then we'll come to you. Okay, thanks.
Okay, we have quite a few. I'm going to start with, how do we get past the barriers of privacy in order to ensure ensure important data is collected?
Well, I mean, that's a great question. And like we've recognized the need to transform our healthcare system in delivery and in data, we have recognized a need to transform our privacy laws that allow us to meet the needs of patients and stakeholders in a modernized way, where their data is is leveraged to help their system run better and help achieve the outcomes that are important to them. So we need to transform our privacy laws also. One of the challenges has been is that the custodians of the data, and it's a removed statement, like aren't they also us in the room? And maybe they are, but have not as easily recognized the need for transformational changes in privacy laws. And so we're working with them and others who are custodians of data so we can figure out exactly the path forward in a way that utilizes the data appropriately to achieve the recognized needs while protecting autonomy and privacy to the extent possible.
So I know we've got a number of questions, so we'll go back and forth a bit.
Okay.
You have a question?
Hi, my name's Jeffrey Thompson. I'm an occupational health nurse. I work at the MFL Occupational Health Center, and we're a little-known WRHA-funded clinic working downtown. And I find it interesting, our patient experience, I'm really glad this has come up, kind of the layering that happens, the complexity of patients who come through the door. And we see folks who might have a WCB claim that's gone off the rails, they need a second or third opinion or just support, but we can't provide a lot of the services. We have to find a way to kind of help refer people. So referral, a need for a more robust referral network for folks like this is really important. My question is, when it comes to data and when it comes to kind of understanding this particular group, I know WCB data is kind of siloed, and we've talked a little bit about jurisdictions and the challenge of kind of getting everything all in one place. I mean, I can do a lot of primary prevention, tertiary prevention to help these people kind of more on a one-on-one basis, but when it comes to affecting policy or affecting kind of looking at this as its own social determinant of health, which is not just employment status and income, but actually what happens in workplaces and some of the inequities that can happen, certainly for newcomers and folks who are new to Manitoba. So we do a lot of cross-cultural work as well. So we're a small community health center. That's kind of our center, is worker-centered healthcare. So I was just hoping maybe you could comment on some of that. So thanks.
I'll take a comment from, but I also wonder, we have Perry Polston here. I just looked down at his feet. Perry is the head of digital health, and as a colleague of ours at Shared Health, very involved in the health system transformation. And Perry, you've heard this issue before around what's our vision for being able to share information more across the different data sources. I don't know if you have any comment on that, and while you're going to the mic, if anybody here wants to speak. Jeanette? Just as a warm-up.
A great question, and I'm very familiar with MFL. I think we should pose that question to Dr. Alan Katz with the Manitoba Centre for Health Policy. The Manitoba Centre for Health Policy now has access to numerous databases, not just within the illness system, which I'll call it. So I think a great question to pose, and we can do that.
So Perry, do you have any comments on that issue?
Well, I was just going to say, you know, now we're looking provincially. We've got a lot of data, as Ryan says. Nathan, I don't know where Nathan's hidden himself somewhere. But we talked a little bit yesterday even about how do we actually access this. We talked about privacy. I think we're in a new landscape now where we're really looking at this holistically, and we've really got an opportunity to really look at the data differently than we've done before. Yes, we have to do it safely. We have to be careful. But I think we're just in a new area where now we can start to leverage this data different than we've ever done before, and especially for Manitoba. So I think we're in a good place.
Thank you. Do we have an online question?
We do, and just a reminder to everyone that we will post these on our website. The question actually looks like it's directed more to Dr. Bohm. How are PROMs administered for knee and hip surgery patients, and what strategies have worked best?
Thanks, Sarah. So we administer these via paper in the pre-admission clinic when patients are being seen getting ready for surgery, and they have a questionnaire that's mailed out to them 1 year after surgery. So it's fairly simple. It is quite labor intensive because you need somebody to take the paper forms and manually enter them into the database, and that's an opportunity for error, mistakes, and so forth. We have looked at doing electronic data capture, and there's actually been a couple of studies looking at that, and I think it really depends upon who your audience is. Some people are much more comfortable and willing to do online data entry. email reminders and things like that. In other patient groups are less so. The average age of my patients is 67. They seem to be more comfortable doing paper and sending it back to us. So I think you really need to understand what your population is and you know, what they're comfortable with doing.
Other questions?
Sure. So another one related to the Mindset project. How do you plan to work with primary care and community healthcare providers in relation to Mindset? The current framework now appears to leave that perspective.
Right. I would say that's critical to such an integrated database, for sure. So whoever asked that, it was very astute to point out that the demonstration projects do not center around primary care at the moment. The intention is very much so to do that. And I presented the first phase of demonstration projects. The idea is to work with our partners, that is the region, that is the government, that is us, the patients, to then, based on priorities and feasibility and champions, et cetera, then expand the database to capture the needs of the next priority in a second and third wave. And it would be completely conceivable and expected that a second or third wave of the expansion would involve primary care, since it's fundamental to keeping us well as a community.
Is Alan Katz here? I wasn't sure.
No, I'm afraid he's out of town, couldn't come today.
Okay, okay.
Just you're mentioning that, if I could just throw in one more thing, the question of, you know, the Workers' Compensation Board data has been in discussion at MCHP. We're hoping to gather some more resources to be able to do that. Another thing I'll just put out there is there was an initial conversation with Manitoba Public Insurance. Right? There's a lot of automobile collisions that cause a lot of injury and a lot of things happening, and that would be another ripe data source that would provide yet another perspective on aspects of people's lives and impacts on health, you know, both before and after. Would be interesting to study.
So I think we'll start winding things up. I'll just make a couple comments and then pass it over to Sarah. Just from my perspective, I too want to thank everybody for coming today and all the people online, and particularly thank the patients who made themselves available. This is very, very important for us in the healthcare system to be able to really have a true sense of what patients are experiencing and clients, and also better understand what the longer-term outcomes are of a lot of the things that we do to patients and clients. And that really will help us better determine, you know, what health services we should be providing and how best to provide those health services. It's absolutely pivotal. So I really want to thank everybody. Really want to thank our excellent panelists and for all the work that you're doing and all your commitment. And I too would like to thank Sarah and the Center for Health Information, which is kind of a coming together of the university and the WRHA and now Shared Health and Manitoba Health as well. You know, those are the principal supporters, principal funders, and I think they've done a terrific job. So thank you to them as well. And with that, I'll pass it over to Sarah to talk about next steps. Thanks.
Thanks so much, Brock. Thanks for everybody here. I'll just tie it up really quickly. If you're interested in getting involved in this project, please contact us, as you can see from our website. I'm just doing some wrapping up we do have an evaluation that has been inserted in those pamphlets that you picked up. We'd really appreciate it if you filled it out. For those of you online, we will send you one electronically. And I'm really looking forward to this project and moving forward. I think this is a very exciting opportunity for us. Thank you, everybody, for coming today.